مرحبا بك يا برو.
سامعني؟
سامعاك وشايفاك، صورتك واضحة وصوتك واضح.
لكن أنا ما شايف الصورة هنا. أها، جاهزين؟
جاهزين.
هسه واضح؟
واضح، الصوت واضح والصورة واضحة.
خلاص نبدأ أحسن مش أحسن؟
آه.
بسم الله الرحمن الرحيم. I would like to welcome you all to this series of lectures on infectious and tropical diseases. We have been covering quite a wide area of some of the important diseases in the tropics. People would like to talk about tropical diseases or diseases in the tropics. There is a difference because if you talk about diseases in the tropics, you talk about diseases which may not be environmental and but are affected by the conditions in the tropics. Maybe like non-communicable diseases, diabetes, hypertension are also prevalent in tropical diseases, but may be affected by one or another factors in the pathogenesis and the outcome, especially when you talk about social factors like poverty and the rest. Okay, in 1981, when the HIV/AIDS came into the scene with an epidemic and then pandemic, which really affected Africa in a very devastating way. And this is we talk about diseases in the tropics. The disease HIV/AIDS in the 80s and 90s have reduced the lifespan of the population in certain South African countries like Botswana and the rest from 52, 53 to almost 35, 37 years of age. So it was devastating, and has it not been for the introduction and the discovery of ART, antiretroviral drugs, the disease could have wiped quite a large part of Africa. So the HIV/AIDS took the stage, and with HIV/AIDS, tuberculosis appeared because, as you know, tuberculosis is latent in many people. But if you break the immunity, then tuberculosis may be overt. And this is not only in Africa, but even in America. The surge of tuberculosis in New York has gone up steadily after HIV/AIDS. So these are the two major diseases. Adding to it, malaria, again, which is claiming a lot of lives. These three big diseases, what we call three big diseases, have been drawing the attention of almost everybody, like governments, donors, and NGOs and academicians. So a global fund, which is a major funding agent, have been set aside, like Gavi. There is another global uh, funding agent called Gavi, which is producing vaccination for free to other countries, especially the 6 major vaccines of children. So Global Fund provide treatment ART free, provide diagnostics of HIV free, and also provides antituberculous drugs free. And likewise, if And the malaria, there is ACT, which is the artemether combination therapy, is also provided free, provided that the country can prove that it has a system of absorbing these drugs. So that was early on in the late 80s and 90s, and then people suddenly felt, especially people working in the classic tropical diseases, they started that the diseases, other diseases are being neglected by the donors, by WHO, by others, and they grouped these diseases into a package. And when you look at these diseases, you find that they can claim lives, but more important, they claim DALIs, which is disabled life years, more, as equal as one of the major three. So they put the argument that in tropical areas, which is affected, we need to alleviate poverty, and we need to help people to get on their feet for work. And this can never be achieved with tropical diseases prevailing as it was. So this call for care about what they call neglected tropical diseases has been very successful, has been extremely successful. Now we are in an era where we are talking not only about controlling as a health problem these diseases, but also we are talking about elimination of some of them. This is due to the effort and very huge public health endeavors or projects or programs has been set for these tropical diseases, especially like OCP, which is Onchocerciasis Control Program in West Africa, depending on spraying of insecticide on the big rivers to kill Simulium damnosum, which is a black fly for onchocerciasis, and then the African program for onchocerciasis control program, which is dependent on distribution of ivermectin. And likewise, this happened to the lymphatic filariasis. And I think of major interest is the development of preventive chemotherapy, which has been adopted highly by the WHO to distribute drugs in mass for control of disease, not for an individual treatment, but for control of disease in the community. And this has been very successful in deworming school children. True, it did not eliminate the disease, but it's a reduction of morbidity and improvement in cognitive function and nutrition of these children. So there is major successes in neglected tropical diseases. And if I am asked, what is the major development in the last 30 years as far as tropical diseases are concerned, I would say two things. One is the development of new, effective, safe, easy to administer, orally given drugs. And this is the major thing. I remember for people of our age and younger would remember how antimonies used to be given for schistosomiasis when they killed patients, okay, maybe before they killed the schistosomes. So it's the improvement of the drugs. Now we are using praziquantel, a wonder drug, which is being given even by volunteers, not even doctors or nurses, and it can work wonders in eradicating and curing schistosomiasis. So I would say that the drugs which have been introduced are marvelous drugs, safe, with a very good margin of safety, and more important is being given free. And this is the major development in control of tropical diseases, thanks to the call and the cry of those who are interested in tropical diseases about declaring that this should not be neglected, should not be neglected, should be careful. The importance of these drugs is reflected on the fact that some of the discoverers of these drugs have been given awarded the Laurent Nobel Prize for the development of these drugs. So it's a major development. The other development is diagnostics. As far as diagnostics is concerned, is the introduction of ultrasound late 70s and early 80s, especially the real-time scanner, has really revolutionized our understanding about many of the tropical diseases, specifically cysticercosis, anything with cyst, because ultrasound is very good in picking up fluid-containing structures like cysts, Hydatidosis cyst, and now we're going to talk about hydatid today, and the follow-up by ultrasound and also by magnetic resonance has revised and has cleared our understanding about the evolution of these cysts and what they should do. More important is that now with the use of ultrasound in hydatidosis, we can do what we are prevented to do before the ultrasound, which is aspiration. Because of the sensitivity and anaphylaxis, which if you leak the hydatid in the peritoneum, you can get anaphylactic shock and death. Now with the guided ultrasound, we can do a lot of treatments under guidance of ultrasound. So the other terminology which I would like you to get is, which is used quite often, especially in WHO arenas and publications, is communicable and non-communicable. Okay, if you communicable is transmissible. It transmits from one person to another. Diabetes is non-communicable because you cannot transmit it from one person to another. So most of the infectious and tropical diseases are communicable. And by definition, it is a disease which is transmitted from man to man, man to animal, animal to man, animal to animal, by different modes and different ways. By air, like COVID, okay, influenza. By touch, like scabies, you can touch the person who has the mite of scabies, and you can get it yourself. You can touch a hand which has been rubbing around the anus for itching of Enterobius vermicularis worm, which is the pinworm, which causing a lot of itching and layers of eggs there. You can wash, you can get the hands contaminated by the eggs from a patient, and then you can swallow it through soil or platform like dew helminths. We can contract dew helminths, and from animals like hydatid disease, again, is contracted by the eggs from dogs. And then cysticercosis, which is Tenisolum, can also be contracted from animals, and Tenisaginated from eating raw beef and contaminated beef. So that is communicable diseases, which can be transferred. The non-communicable diseases are diseases which like cardiovascular, heart disease, renal disease, cancer. These are non-communicable. And I would like to draw your attention that the tropics or the tropical countries are not spared of these diseases. We used to think early on that because of the diet, which is high fiber diet, and the way the people are living here with exercise being done as a routine during the work, that the communicable diseases are not prevalent in tropical countries. But this is not true. Nowadays, we are seeing a continuous rise of non-communicable diseases. So it's coming up. So the burden of two diseases, non-communicable, in tropical countries is extremely important. This is why when the Institute of for the Research in Sudan, when it was inaugurated, we called it Endemic Disease Institute, Endemic Disease Institute, which in a way encompass diseases of communicable and non-communicable. True, non-communicable are more, but the non-communicable can be also included. Today's lecture is about a cyst. You remember last time, last lecture, last Sunday, we talked about cysticercosis, which is a teniosolium, which is a pig tapeworm, and human can be infected by the eggs, oncospheres, and then they can go into development of cysts in the body. It's a very malignant disease. It's a very malignant disease because it predilect or has predilection to central nervous system, especially brain. And as we have detailed last lecture, that 1/3 of those who have epilepsy in Latin America and South America are due to presence of this intermediate form of teniosolium. So it's a cyst, which is the larval stage of teniosolium causing that much of epilepsy. And again, in India, in children, epilepsy in children is dominated by the presence of the pigworm or cysticercosis. Okay, another cyst which we will like to deal with on this lecture is cystic echinococcus. Cystic echinococcosis. Echinococcosis. Okay, and echinococcus, capital ECCHI, echino, NO, coccus, COCCUS. And if you add IS, meaning disease, echinococcosis, meaning the disease which is called by Echinococcus worm. And it would always link, talking about cystic, we add cystic at the front, we call it cystic echinococcosis. That is a disease caused by this worm. And or we can call it cystic hydatid disease. Cystic hydatid disease. All right. I want to bring one of the eminent scientists of our country, a lady who used to, I talked to somebody about echinococcosis because some people would pronounce it, and she said, Professor Sami Ahmed Juma, who is a well-known microbiologist, parasitologist, and mycologist from the University of Khartoum. She taught in UMST. Is a great lady, Sami Ahmed Juma, and she was honored by the university on calling one of the big labs under her name. This is one of the great ladies of Sudan, and she used to insist on the pronunciation of Echinococcus. So this is hydatid disease. What is it? Hydatid disease is still prevalent, and we estimate that there are 3 million new cases every year. 3 million every year. Simply, it is a disease, the intermediate form of this disease caused by dog tapeworm. You remember we have tapeworms like Tinosagenata, Teniosolium, but this is a tapeworm for dogs. It is dog's tapeworm. So, and dogs excrete eggs, okay? And the circle goes from dogs, eggs, sheep, for instance, or camel, and then eating the dog again, eating the raw infected meat, and then they develop the worm. So the circle, man has nothing to do with the contribution to the circle, all right, or life cycle. But unfortunately, man can be caught as a side victim of this. So it is a worm, a cystode, it's a tapeworm, and here it is a small worm. It is only composed of three pieces, three proglottides. This is a segment is called proglottitis, unlike the Tinea saginata and Tinea solium, which is may reach up to 10 meters, okay, with proglottitis being, detached as they mature and goes in the feces. So this is this Tinea solium of animals, of dogs mainly. In certain places is fox, but the common one is dogs. So it is the man, if I can, Arwa, if she's there, if she can show us the life cycle.
Okay.
Okay, so it is a small worm in a sense in comparison with other cystodes or tapeworms, and it is prevalent where the dogs are befriending the humans, are living with the humans, but eating carcass, eating meat which is thrown to it, and they contain a lot of infection. And one area in in Kenya called Turkana, which is a county, which is North Kenya and neighboring South Sudan in Kaboita region. These are what we call paradise for Hydatidosis. And early doctors who worked in Kaboita had a lot to do with Hydatitis surgery, like Professor Zakiddin Ahmed and others. Okay, there the dogs are, living like human. They go into the bed with them. They go hunting, and the dog is vital. And some of the areas which has no water, the dogs is made to lick the child bottom after defecation. So they are so close. And this is not from my head, it's even written in textbooks. And that some of the dogs with women cleaning their menstrual cycle by the dogs licking them up. So it's so close. Okay, Arwa is there. Okay, so uh,
الشاشة واضحة؟
ما واضحة نحن أنا ما جاتني.
اه أي شيء بالتالي.
Okay, anyway, yes, this is the one. Put it up. Is it clear for students who are listening? Can you see it? Yes. Okay, if you look here, the life cycle of Echinococcosis granulosus, the top is a tapeworm, which has, like a balling, it's heavy or bigger on the bottom and has two other segments, and these are in the dogs. The dog here passes eggs, and the eggs mature to be called oncospheres, and the oncospheres is taken up by the sheep or camel. In Sudan, it's very much in camel, okay? Hydatidosis in camel, because as you know, people eat the liver of the camel, and it's raw. You cannot even heat it, or you cannot even cook it. So it's raw and it's infected, and then it goes up to the dogs. This is meat which is thrown to the dogs, and the dog will eat the larvae, oncospheres, and then it goes into a full worm. Man is not known to develop the adult worm. Man is not known to develop the adult. So if you look on the right side, we say man, okay? This is from the eggs coming from the dogs. They go into oncosphere there, and then they go man. This is why I say it is an accidental or incidental that man can get infected with the eggs of the dogs, the eggs of the dogs. So they only harbor the intermediate form of the disease. Okay. Um, as we said, with the ultrasound, now we can study the evolution. So it is a cyst of various size. It's a living cyst because we have simple cyst in the body, as in the liver. It has one single ring, the simple cyst. But here, has a complex walls. Part of it is a human wall, which is being created as fibrous tissue around the foreign body. And then the larva itself has two walls. One of them is the laminal wall, and the other is germinal wall. The germinal wall is the living part of the worm, and this is generate a lot of scoliosis, heads, a lot of brood capsules, a lot of sand, what we call hydatid sand, and then they can breed new daughter cysts within, or they can get them out into the circulation. So this is the hydatid cyst. So simply, it's a disease of a cyst. Okay, where is the cyst? Depends on the symptoms. Depend on where is the cyst. If it's in the liver or it's in the lung, 80% of all hydatid cysts are in the liver. About 20% or about 10 to 20% are in the lungs. 10% are in other places like brain, bone, spleen, kidneys. They have these cysts, but majority is in the liver and in the lungs. Okay, so they create a space occupying lesion, in that particular organ. If you have a space occupying lesion in the brain, you get headache, you get papilledema, and the rest of it, you get irritation like epilepsy. Okay, if you have a space occupying lesion of the cyst in the liver, you can get upper abdominal pain, you can get stretching, and you can get pressure on whatever tissue you are neighboring. So if you press the hepatic veins, then you get a syndrome called Buck-Chiari syndrome. Okay, if it presses the common bile duct, it gives you obstructive jaundice. Okay, if it presses the lungs, the bronchi, it gives you atelectasis. If you block the bronchus, then the distal part will have a death of the lungs and called atelectasis, or retention pneumonia due to the obstruction of the bronchus. Okay, so that is understandable. But what is more dangerous is if the cyst breaks and it creates, like in the biliary, in the liver, it can create a cystobiliary fistula. And you can imagine, the mess the patient will be in. First, the fistula can be infected, the biliary system can be infected, and then gives fever, rigors, and then they get jaundice, like obstructive jaundice. And here, the two enzymes which will go up are alkaline phosphatase and gamma glutamyl transferase. So this is if you get into the biliary system. Okay, so this is one of the acute things which we care for, is to treat surgically this cyst. In the lung, If you have a cystobronchial fistula, then you can get the cyst material being expectorated into the sputum. It can, the sandy water, the watery, even the scoliosis can be coughed out. And then in both cases, you can get an allergy because the fluid of the cyst is allergenic. It causes allergy. So it's very important to remember that the cyst has a space-occupying lesion and it has an effect of opening up. If you can have the other picture, other photo, that is the cyst, if you can get the cyst, Arwa. And as I said last time, I have a disclaimer here that I photoed these pictures from books. The major book is Manson Tropical Medicine and Oxford Tropical Medicine Pocket. I needed to do this because we have very beautiful pictures and photos back home. Unfortunately, we are locked away. We cannot use them. Now I'm using this for non-commercial reasons, just for lectures, which is disseminated for free. So there is no conflict of interest here. Okay, Arwa is finding difficulty in getting the cyst on the screen. So the major problem with the cyst is if it leaks into the peritoneum. And if it does so, it can cause severe allergy. Severe allergy is very fluid, is very allergenic, and can lead to anaphylaxis and shock. This is why, before the advent of ultrasound, we used to say puncturing any cyst is dangerous if you are not sure this is not hydatid. Because if it's hydatid and you puncture it awkwardly and the fluid leaks in the peritoneum, anaphylaxis shock can occur and kill the patient. But now there is a treatment under guidance of ultrasound, which we come to it, is called PAIR, capital P, capital A, capital I, capital R, PAIR, which is puncture, aspiration, injection, re-aspiration. So PAIR, P for the puncture, A for the aspiration, I for the injection, and R for re-aspiration. This is nowadays is a treatment of choice for big cysts, which we can give them down. Okay, if you can see the photo, is Arwa there? Arwa disappeared. Arwa. Okay, this is this. Okay, this is okay. So
ظهر السيست
ظهر السيست. في تاني سيست انا راسمها باليد. Okay, so just look the bottom one. I would just like you to visualize that the cyst has a very thick wall, and this wall is composed of the human fibrous tissue wall, which is adventitia. It's called adventitia. And then there are the other laminal cyst, which is part of the worm, which is part of the larva. And then these small rounded things are scoliosis, like brood capsules. These are small, more small worms. Okay. And here we can see the ultrasound picture, which is showing here multiple cysts up there, one cyst with walls, and the other cysts are multi cysts. Okay, so there is one. I draw it by hand, Arwa, if you have it. Anyway, so that is the cyst, and it has a very thick wall. Okay. Uh, the treatment treatment is of two parts. Part one is drugs. Okay. Uh, Drugs like albendazole, and you remember that albendazole is coming on and on and on for a lot of worms, a lot of diseases like preventive chemotherapy of lymphatic filariasis for all the intestinal worms, intestinal nematodes, which is albendazole is very effective. Here we can give albendazole as per only, or we can give albendazole joined to other surgical or semi-surgical interventions. Okay. Albendazole can be given here in a very high dose, it's 400 milligrams. 400 milligrams, that's 2 tablets because the tablets is 200. 400 milligrams twice a day. So that is to say, it's 800 milligrams total per day for 3, 6, or up to 12 months, depending on the response. And here we look into the response by ultrasound. We can see that it shrinks, coming down, or it is not affected. So it's the evolution of the cyst can be very, very clear in this sense. So it's albendazole. All right. The pair, the puncture with ultrasound, the important thing is the needle should be very sharp. It goes in the cyst and it draws at least 30% of the fluid, takes it out. This is why we call puncture aspirate. We aspirate the fluid which is inside. And then we inject a scolecidal agent or fluid. Scolecidal, it kills the scolysis, because the livelihood and the vitality of the cyst is presence of scolysis. These are the small worms which will grow into the big worm. All right. So it's you have to take at least 30% of the fluid and inject scolycidal, which is either hypertonic saline, in the same amount you have taken, or ethanol, 95% ethanol, as given injected back. Okay, leave it for half an hour or so for some time, and then aspirate to dryness. You can aspirate the whole thing now with the hypertonic saline or the ethanol. You can take it out completely, and then you can see that the cyst collapses. This has to be followed up because maybe that some scoliosis are still alive and they can grow into a new cyst. So you have to cover it with albendazole and observe it by ultrasound. That's by ultrasound. Surgery. We used to do a lot of surgery before the advent of ultrasound, before the advent of albendazole. We open up and we take the cyst. This is being done, still being done in the lungs, particularly in the lungs and in the liver. Okay, here you have to be very careful. If you can do a very careful toileting, all right, wrapping whatever viscera is, separating the liver from the rest of the peritoneum so that you will not leak any fluid into the peritoneum. If you can do that, then surgery can be cleared, because once this fluid in the cyst comes out into the peritoneum, it can cause a lot of allergy and sensitization and anaphylaxis shock. Okay, one of the surgeons in Sudan who is very much interested in Hydatidosis has done a lot of research in collaboration with some German institutes is Mohammed Al-Lamin Ismail. He's a surgeon who is interested in Hydatidosis and has done a lot of surgery. Okay, obviously, cysts within the lungs are not accessible like the cysts in the liver. So it is this is hydatid. It is a worm, it's a worm which is called Echinococcosis granulosus, cystic, because man is just incidental, incidental in the life cycle of it, can swallow the eggs from dogs. Oncospheres can go in and they can develop into cysts, mainly in the liver, about 70 to 80%, and in the lungs, about 10 to 20%, and the rest of 10% is in the brain, in the spleen, bones, and peritoneum. So this is the clinical features is of pressure. Wherever the structure is, you can pressurize that area. You can open the cyst into bronchi, giving you all the symptoms which you have dealt with, or it can open up in the biliary system, again giving you the cholangitis part, the cholangitis part of it. So that is Hydatidosis cyst. I don't know if there are any questions before we proceed to another topic. Arwa? Okay, this is the one which I drew by hand.
Okay, sorry.
Okay, this is Hydatidosis cyst, and it shows the germinal layer which is rounded, you know, like small vesicles there, broad capsule. This is a daughter cyst within there, and there is a sand, Hydatidosis sand. Okay, and then on the left side there is exogenous cyst which has come out, and this is inactive living larva. This is active living larva because it grows. If you follow it by ultrasound, it grows 1 to 2 centimeters diameter every year. So it is active and it is live and vital. If the germinal layer falls down onto on the fluid, it gives you a lot of signs in the ultrasound, which is called Lilly sign. But anyway, these are the things which you can observe by ultrasound. Okay. Now we turn into another topic, which is scabies. Scabies. Okay. Scabies is the common name in many parts of Sudan, especially Jazeera. They call it jarab. But jarab is a very common name. Jarab meaning that it can be contracted from one person to another. A jarab. Okay? But this is a very contagious, highly contagious disease. And it is caused by mites. Okay? And it is called, the mites are called Sarcoptes scabies. Sarcoptes scabii. Sarcoptes is Sarcoptes. Sarcoptes scabii. Scabii is Scabiei. Scabii. These are mites. Okay, and it's an old disease. And at least every year there is 300 million new cases. 300 million. It's not restricted only to tropical countries, but even in temperate climate, these mites can infest the skin, epidermis, and they can burrow themselves into a furrow, like جداول كده في اليد, mainly in the hands and the feet, and in the webs between the fingers and toes. So we call it not infection, it's infestation, because this is a higher level, زي الحشرة, infestation. Okay, it's worldwide, especially in disadvantaged population or populations in institutions, okay, and malnourished children in schools. It can intrafamilial from one person to another, very, very contagious from one person to another, or sexual contacts. So if you have it, if you have scabies in the groin, this is through sexual contacts, and then intrafamilial from any place. So this is one of the diseases which you can go from one person to another even without an intermediary. Um, so what happens? The mite gets into the epidermis and burrows itself. It penetrates. It penetrates the intact epidermis. By what? By enzymes. So it releases enzymes which will soften the epidermis, and the mite can go in the epidermis, and there it can cause furrows like serpiginous tracks, red tracks. You can see the red tracks in the hand, okay? And this is contains the mites. What happens is mites, male and female, mate, and they mate once in their life, and the female gets fertile the rest of its life. So it's with one mating when the mites can produce eggs like 3 eggs per day for 6 weeks. Once the male mate with the female, after the action, it dies. Okay? And the female itself, within 6 weeks, dies. Okay? So the eggs can continue the life cycle, but the adult mice will die very soon. So what happens? What happens is that the eggs mature, okay, and then they get into adults, all right, into adult mice, and this takes about 2 weeks. Okay, what is the lesion? The lesion is classically in the hands. The lesions are areas, crusted areas, or pyodermic area, which is pus, and they cause abscesses, small abscesses in the hand, and it is very itchy. It's very itchy. It's very, as much as highly contagious, it's highly itchy, very itchy. Okay. وفي السودان في بعض المحلات بيقول لك الحنكله ابحك نحله يعني شنو؟ لما when you rub, when you scratch it, all right, by hand or scratch it by a stone, then it gets relieved. This is why it just gives you the impression that this is very highly itching, you know. The other disease you remember, which is very itchy, is onchocerciasis. Again, it's a disease of the microflaria under the skin. This is the mites here in scabies is under the skin. Okay, infection with two bacteria is very common. This is Staphylococcus, Staph aureus, and Streptococcal pyogenes, which is group A. These are special bacteria which is known to infect the lesions of scabies, and they have been even recovered from the pellets of the mites. Pellets is the feces, the small feces of the mites. Okay, if you culture it, you can grow streptococci and staphylococci. So the infection is very much common in patients with scabies. Okay, so what will happen is contagious if you touch the hand, if the crust come out and falls in the linen, all right, somebody use that linen apart from the patient, some in the towels, you know, these are eggs being present there, and they can go into the epidermis and cause scabies. So the lesions in the hand when starting, they can be papular, they can be vesicular, okay? And then sometimes in immune suppressed patients, they can get generalized erythematous papular eruption. All the time, you should remember that patients with competent immunity may present less severe infection. You remember strongyloides, stercolaris. We have talked about how this worm has come to the surface so badly and so lethal after the HIV/AIDS came to the scene. So here with scabies, if the patient is being attacked by scabies, by the mites, then if she has immune suppression, then they can get a generalized erythematous papular rash with a lot of mites. Okay, and we already said that the predilection is the webs of the fingers, of the toes, elbows, wrist, periumbilical, pelvic, buttocks, okay, breast, especially in women, These are the areas which are favorable for the scabies. So if you have a patient who have immune suppression, then you get what is called crusted scabies. Crust is a layer ناشفة كده, crust, which is almost like a healing, but it's a very thick crust, okay? And this is like keratolytic, which is giving you the impression that there is a layer on top of it. Okay, I think there is a picture of this crusted lesion due to HIV or in scabies in HIV. Arwa? Okay, this is scabies in the hand, okay? You can see that these are the biodermic lesions, this hand, okay? And it is between the fingers in the webs. Next, Sani. Okay, next, Arwa. Okay, we have a picture on the legs and the crusted, yes, this is again scabies in the feet. You know, you cannot miss it. If you see it once, you cannot miss it. See how inconvenient for these scabies to be in the feet. You cannot even walk. Okay. Next, there is another one. The last one. Yeah, this is again in the penis. Again, this is very bad, very ugly, and then it can be contagious in the groin. This is the groin and the penis. Next. Okay. Uh, I would like to see the crusted lesion, which is important because with HIV, AIDS, then the whole tropical and infectious diseases may look different and severe. Okay, the itching is during the day, but mainly during the night. So if during the night, it's the itching is very severe. Okay, and this is again just like other itching with Tropius vermicularis, perianal itching. Okay, it's giving you the sense of coolness and sweating, which bring up the worm down. Here again, it is in the evening. You should avoid. Corticosteroids. You should avoid corticosteroids because corticosteroids will depress the immunity, will break the wall of the immunity, and give you an exacerbated infection. So scabies is common, very common all over. Scabies is a mite infection. The mite is called Sarcoptes scabii. Sarcoptes scabii. I'm sorry that I have to do it every time because these names are not very easy to remember. Sarcoptes scabii. Scabii, the name is scabies. Infectious, very contagious, very itchy, predilate the epidermis of the webs, legs, groin, and it causes severe itching and commonly are infected by staphylococci and by streptococci. Okay, what is the treatment? I have about 4 minutes to finish up the treatment of scabies. Okay, like most of these diseases which are intrafamilial, then hygiene of the whole family, or if it's in a school, hygiene of the whole school. I remember we had an outbreak in a school in Thora, okay, going from one school to another. So we did a lot of work trying to curtail the infection and giving them drugs, okay, as we come to. So you have to, the public health measures within the house or within the hospital or within the institution has to be catered for. Linen, underwear has to be cleaned with hot water, leave it in the boiling water for some time or hot water, and then if they are ironed, then the eggs will die. So that is very important to curtail the infection going from one to another. So that is a general measure. All right. Once you itch, you take the eggs into your fingers, and then if you shake hands with anybody, then you can give it to him and give him scabies. So it is important that you should care about the general public health. Okay, the specific treatment. The specific treatment, there has been a development, very good, important development. All right, you can have permethrin, okay, P-E-R, methrin, M-E-T-H, okay, permethrin, T-H-R-I-N, permethrin. And this is cream, 5% cream. This can be rubbed over in the areas and maybe the whole skin. Okay, permethrin, and keep it on for at least 3 days. For 3 days. Okay. The other drug, apart from permethrin, is benzyl benzoate, which is 25% concentration. And here we rub all the body by benzyl benzoate, leave it for 24 hours, repeat it over 3 days. So these are the two topical cream and ointment for the scabies. We add ivermectin. Which is a drug we have been talking about for quite a long time. And ivermectin is to be given in 200 microgram per kilogram body weight. The tablets of ivermectin is either 3 milligrams or 6 milligrams. We used to use the 6 milligrams, but lately we use the 3 milligrams. So you can multiply 200 microgram per kilogram body weight and then calculate how many tablets you can give. It's usually a drug which is fantastically tolerated by the human being, by the body, and very minimal side effects. Okay, ivermectin is particularly important when you have crusted scabies. Okay, when you have crusted scabies, ivermectin. Anyway, I have treated a village in the Jazeera by ivermectin. I gave ivermectin for the whole village, and the scabies went down very rapidly. But I think dermatologists will always like to give ivermectin with permethrin or benzyl benzoate. So in summary, scabies is a common problem. More people are institutionalized. It is a mite which can be infected easily. It causes very severe itching. I would like to emphasize very severe itching. It's highly contagious and it can be infected, but treatment is possible by either a cream, permethrin, or benzyl benzoate added to ivermectin. The other name of ivermectin is mectizan, which is produced by Merck. We'll finish today's lecture, and thank you very much indeed for being with me. Thanks to Arwa for preparing the slides. See you next Sunday, inshallah.